without slurring, then you have to arbitrarily give them the worst score of the two.
Are you saying give an intubated patient a tube?
You can't, no, you're gonna end up giving them 0, actually. Best gaze, ask the patient to follow your hand with their eyes back and forth. We're just testing horizontal eye movements. I sometimes will expand that to vertical eye movements too, but the NIH stroke scale, this is what we're scoring. I can do a lot of this exam without you even in the room. I can say, look to the right, look to the left, like that. But I get a more robust exam if I have your hand there and something for them to follow, that sort of thing. So the way you score this is you score a 1 if they have, very often the gaze problem is related to a middle cerebral artery stroke. You think about eye movements as being from the brainstem, but you have something called the frontal eye fields up here that drives your eyes to look toward the side of the stroke and away from the side of the hemiparesis. So in a right middle cerebral artery stroke, you'll be staring over toward your right hemisphere, but you'll be paralyzed on this side. If you're stuck over there and you can't get them to make their eyes go over to the other side, we call that a 2. If they just have a preference, but working with them, you can get them to look over to the left, that's a 1. So that's with this kind of a problem. When it's a fixed problem, that's more hardwiring in the brainstem for gaze. So let's say they have one eye deviated down and out and it won't go anywhere, it's stuck down there, a third nerve palsy, that's a 2. If they are comatose and you can't tell them to look this way and that, what I do is I grab a hold of their head. Are you guys familiar with the Dowell's maneuver? It's a way to check eye movements in a comatose patient. So, when your eye movement function is working, but you're comatose, usually you open up their eyes and they're staring straight ahead. And then if you swing their head to the left and right, their eyes will roll, so the eyes will look straight ahead while you turn their head. That's an intact Dowell's maneuver. That means their reflexes are working, those nerves, their brainstem is working. That's a good thing. If when you do that though, their head, their eyes just stay in the same place in their sockets, that's not good. That means their reflex isn't intact, those functions in the brainstem aren't intact. So you just grab a hold of their eyes and swing their head back and forth. You have to be a little aggressive, jerking back and forth to see whether it'll move. And it doesn't always bury their eyes in the corner, but you'll see a little excursion to that side. So you have to look closely for it. But that's how you test that, so you can test it. So in that kind of a comatose situation, you're probably either going to use 1 or 0 or 1. So they either have intact eye movements or they're not moving at all and you give them a 2. Visual fields, so you use finger counting or hand movement in all 4 quadrants. I find it the easiest to get in front of the patient and check both eyes at the same time, and then if I have to drill down and do one eye at a time, covering one eye, I do. But this is the quick and dirty fast way to do it that I'll keep, if you're doing it a different way, I'm sorry, but I'll keep correcting you and I'll say, why don't we do it this way? So I want to test all 4 quadrants. So here, 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 and here. So I don't need to check up here or here because that's in both fields really. So here, 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 and here. And so I put up both my hands. I say, look at my nose and tell me which hand is moving. And then I have to do the same thing in the upper quadrant. So it's really 6 individual tests, each quadrant individually. And then when I'm doing this, I'm checking for what I call visual neglect. So let's say she could see this one, this one, this one, and this one, but when I did this, she ignored this one over here and only saw this one. That's visual neglect. So the way you score this then, you use it for the visual field testing here, but you also use this information for the neglect testing. So you score 1 if they have a quadrant out, or if they just have visual neglect on one side, but all 4 quadrants are intact. 0, of course, is everything that's working well. 2 is if they have a hemifield out, so she didn't see anything in that quadrant or that quadrant. 3 if they're completely blind, so they don't see anything. And to your earlier question, if they are blind from birth, they're gonna get a 3, because this needs to be a reproducible exam. If they're comatose, you arbitrarily give them a 3. One kind of funny thing that you might not be obvious is, let's say they have retinal artery ischemia, and their vision is out in one eye. And so you have to, kind of hover to see that that's the case. Yeah, I can't see anything. Yeah, I can see in all 4 quadrants here. Okay, so you can still check the function of their occipital lobes using this eye. That patient with, complete loss of vision in one eye is going to get a 0 because all 4 quadrants are intact in the good eye. So yeah, some ischemia is going on or they have a problem with that eye, but we're trying to test occipital function with this test, and you can test it with the one eye. Okay, makes sense? So that's, when we need to, we're going to have you covering one eye and seeing whether or not, is this both eyes and an occipital problem, with a hemifield out, or is it one eye, and so we'll drill down if we need to for that. Oh, yeah, if, let's say you have our gentleman with Wernicke's aphasia, and he has no idea, he's waving back at you when you wiggle your fingers, and he doesn't know what you're asking him. Then the way you test is, she blinked, she blinked, she blinked, she blinked. I got all 4 quadrants. And it's not a very good test, but it's what you have to use. So, if you have someone who's aphasic and that's all you got, that's what you use. So, yeah, so this is just about the scoring. So the hemifield, left eye, right eye, is going to get a 2. The quadrant out is going to get a 1. And also neglect is going to get a 1. And then if you had one eye out, but the other eye was working and all 4 quadrants, you're getting a 0. Or both eyes obviously were working, you get a 0. Face, you ask them to pantomime and get the patient to move their face, smile, show your teeth, raise your eyebrows. So you give a 1 if there's a little nasolabial fold flattening, but they can move that side of the lower face fairly well. If they're like this when they smile where it stays down, it's going to be a 2. But then they can still move their forehead up here. It's going to be a 3 if they have a Bell's palsy look to them, where when they try to close their eye stays open and they can't wrinkle their forehead. It's also going to be a 3 if you have a patient, let's say they had a stroke 3 months ago, and it affected their right side, and now they had a stroke on the other side, and both sides of the face are weak. And sometimes it's hard to figure out, do they not understand what I'm asking them to do? Because neither side of the face is working, and you don't have anything to compare. Those patients oftentimes will be like drooling and can't handle their secretions because they're weak bilaterally in some of the oropharyngeal structure as well. So that would get a 3 as well. And then if they're comatose, by our NIH stroke scale definition, you're going to arbitrarily give them a 3. Motor function, you guys, knowing the NIH stroke scale, know this, I don't have to say, but 10 seconds in the arms, 5 seconds in the legs, watching for drift. We usually don't do this, we usually do this so that we can see little bits of motor weakness where your fingers are curling, and would count that potentially. The 1 for drift without hitting the bed, 2 for they drift down and hit the bed before the end of the count, but they had some effect against gravity. 3 if you had to put them up there and they just go flopping down, but they have some little function left in their arm. 4 if they've got nothing, or the best that they have is posturing. Same scoring system for the legs, but it's just 30 degrees off the bed and 5 seconds. Oops. Okay, so what if you have an aphasic patient? Well, make sure that you're not just saying, put your arm out there and you score them because they didn't do it. What if they just didn't understand? Show them what you want them to do. Pantomime. Make sure you're getting a test of motor function and not of comprehension. Okay, limb ataxia, finger to nose and heel to shin, so this kind of a thing. So I will oftentimes, I try to streamline my exam as much as I can. So maybe this is a good time to talk about how I do it. Get up on video, I'm listening to their language, I'm looking at their level of consciousness. You guys give me free rein to do my exam with you, and then I ask them, how old are you, and what month is it, and I have them follow the commands. And then I'm done with those 3 items and my aphasia and dysarthria. I've been evaluating all, so I've got 5 sections done. And then I move down to cranial nerves, have you help me with the visual fields, look at their face, eye movements, done with that section. So I kind of think of it in these 4 broad sections. First, level of consciousness language, then cranial nerves. Then I go to motor. And when I'm doing motor, when I have their arms out there all ready for me, I say, touch your nose with your hand and bring it out again. Touch your nose. And then I've got their ataxia done at the same time that I'm testing for their drift. I do the same thing with their legs. I've got it up for 5 seconds. Okay, now put that heel on top of the other knee. Run it down the shin and back up again. And so you get all of that together. So, and then lastly, sensory, I have you guys pull out a Q-tip, break it in half so you have something sharp, poke them on either side, and then finish off the neglect with the touching with your hands on either side or both. So if you think of it in those 4 sections, that's how I'm going to run through it. And we get it done in minutes when we do that. It's not a long test at all, and get good results. So ataxia is a little different than motor in that each limb is scored separately for motor and drift, but with ataxia it's all in one score. And so you're looking for something that looks like this, or in heel, knee, shin, kind of zigzagging up and down. Not this. And not really past pointing either. That's not really ataxia. Ataxia is a real wide tremor that kind of crosses different planes. Not a fine tremor. That's going to be more like familial tremor, or they drank too much caffeine, or something like that. So we want to make sure we're not including those things. And you score 0 if none of the 4 limbs are ataxic. You score 1 if 1 is ataxic, but the rest are fine. You score 2 if 2, 3, or 4 limbs are ataxic. So there's no 3 or 4 in the score. So it's you have it or you don't, and the highest score you can get is 2. This is the only one where if you have a coma patient and they're not moving anything, that you're going to arbitrarily give them not the worst score, but the best score, the 0. Okay, one of those things you got to remember. Yeah. The other thing too is if you can't test for it, because they're plegic and let's say they're awake, aphasic patient, and they're plegic on this side, you can only test for ataxia on the other side. So you don't give them points related to this hemiplegia on the other side. You're just scoring whatever you see on the good side. Okay. Sensory, you test with pinprick, like I said, get out Q-tip, and don't do sharp and dull. It takes too dang long, and it requires too much discrimination for this patient, kind of an extreme situation. So all I'm asking is that you compare left and right sides. Is it equally sharp on both sides? And it's easiest to take the same point. Sometimes people try to be real efficient and go like this with 2 ends of that broken Q-tip, but sometimes one is sharper than the other because of the way it broke. And so it's best just to go back and forth and say, does it feel equally sharp, giving them multiple samples on either side. Same thing in the arms, same thing in the legs. And stay a little away from the distal limbs unless I'm asking you to test that specifically, because oftentimes we run into neuropathy down there that kind of screws up our thinking about left and right sides. So I would test proximally. If their presentation was, I came in with face and hand numbness, well then we're going to obviously have to test both hands and compare the two. Score 1 for partial loss. So I can feel it, but it's not the same as this. It's not as strong as it is on the other side. You score 2 if you poke them, and I can't tell you're poking me. I can't tell you're touching me. That's a 2. So what if you have someone who is, when you poke them, they can't feel it at all here. They're anesthetic here. But here, they can feel it, but it's diminished. And here, it's normal compared to the other side. Well, you give them the worst score. So if their worst is in the face, where they can't feel it at all, you're going to give them a 2. If you have someone like a lower brainstem stroke, where they're numb on this side of the face and this side of the body, you don't give them a 2 for 2 sides being affected. You'll give them probably a 1 because it's going to be diminished and not completely out. Okay? Does that make sense, everybody? Okay. Comatose, arbitrarily give them a 2. If they're aphasic and they have no idea what you're asking them to discriminate, I ask you to notice what's happening when you're starting IVs. If they didn't even flinch when you poke them real hard, we'll give them a 2. If they have less of a facial response for one, excuse me, one side versus the other, I give them a, is that my leftover coffee? I give them a 1. 0 if they seem to respond equally to both sides. What's that?
Her language is changing.
Oh my gosh. Yeah, and you're all equipped to handle it. Okay, last, neglect. So you've done the visual part of this test, so you need to do the sensory part. So, you're just done doing your pinprick testing, and so you go to your patient and you say, okay, close your eyes. I'm going to touch you on the left, right, or both sides. You tell me which. You really need to do all 3 because what you're wanting to see is, do they have sensation on that side? And do they have sensation on that side? And then, do they neglect it? If they don't have any sensation, if she's anesthetic on that side, you can't use this test to see if they neglect things on that side. So, so a classic neglect would be, yeah, I feel it. Yeah, I feel it on the right. Now I feel it on the right. Okay? So let's say you have someone.
What makes them say that?
What's that?
What makes them say that?
What?
If you can feel it once. If you can feel it if you touch me one time, but you can't feel it when you
I don't understand that either.
Oh, I'm sorry. Close your eyes. Which side am I touching? Which side am I touching? Right. Which side am I touching? And she would ignore that side if she had sensory neglect. And she would just say right.
But what makes that happen is what I'm wondering.
Oh, parietal lobe.
Oh.
I'm sorry. That's something very basic, yeah. Okay. Yeah, no, that's a parietal lobe function.
Okay.
So, yeah, very important to do that part of the test. Well, let's say you have huge, I'm really sorry, but you have a huge right middle cerebral artery stroke. She completely took out her sensory cortex. She has no sensation on that side. She has no vision on that side because she took out all the visual radiation. Yeah, I'm really sorry. So here's what I do. I take her paralyzed arm and I bring it over into her good visual field and I say, whose hand is this? And she'll tell you that it's yours. She won't know her own hand. And it happens all the time. So if they have that, I call that asomatic nausea. They completely divorce themselves from that side of their body. That's profound neglect. Then you just arbitrarily give them the worst score of 2.
So that person would be able to say that they feel your hand on the
No, they couldn't.
But what if they can't speak at all?
If-
These that aren't speaking?
Very good. Okay, neglect is very commonly a right hemisphere function, and most people have their language in the left hemisphere. So that's not usually the case. But you can have neglect with left hemisphere. And so most often when I've got a patient with aphasia like that, if I don't know, I'm not scoring that they have neglect. If I get the sense that I can tell that their visual field is intact, but I get the sense that they're just visually ignoring everything on the right side of space, I'll maybe give them a 1. But you can't be real clear when you have an aphasic patient whether or not there's neglect, because it does require them to respond to you and to understand your speech in order to get there. Yeah, that's a hard one. And, we'll just, when I'm doing an NIH stroke scale with you, I'll just guide you in that one. I'd say, let's give a 0 for neglect for that one.
So when you do that, you'll be telling us out loud what you're scoring.
Yeah, absolutely we can. Yeah, and we should. We should try to marry our
Right.
exams together. Lastly, comatose, arbitrarily give them the worst score at neglect. So you give them a 2. So just getting
the best score ones.
Getting back to that, let's say you have a global aphasia patient, hard exam, nothing coming in, nothing going out. How do you score these hard things? Well, first of all, you have all these 5 scores, the first section of my 4-part exam. You have all of those just right off the bat. Nothing's coming in, nothing's going out, but they're awake. So you're going to give them a 0 on level of consciousness, or maybe they're drowsy, you give them a 1. And then level of consciousness questions, commands, language, and dysarthria, you arbitrarily give them all the worst scores for that. So you've got that section done. And then for cranial nerves and someone with that severe an aphasia, you're doing the visual threat. For vision, you're watching their face to look for the facial asymmetry when they grimace or whatever when you're starting their IV, anything you can get. And then for eye movements, you're clapping your hands, come look over here, and you're just trying to get their attention to see whether their eyes will move. So it's a hard exam, but you can do all of it. And then you have to physically put their arms up there to make sure that you're getting a motor test when they don't understand what you're saying. Same thing with the legs. Ataxia is kind of tough, so I'm just watching, you know, a lot of times global aphasic patients are paralyzed on their right side, right? So I watch with their left hand when they reach out for something, do they look ataxic? You know, because it's hard to get them to, you know, do the heel, knee, shin, or finger, nose, finger. So you just watch their movements. And then sensory, you're going to watch their grimace when you're starting IVs, and neglect, like we said, is pretty tough. So that's how a global aphasia exam happens. Coma, with all those arbitrary scores, you'd think it'd be hard, but it's very simple. All you really have to do is say, how do I define level of consciousness? 3 is coma, and it's defined by motor function being bad in all 4 limbs. So you get 4s in all 4 limbs, that's 16 points. And so all the other scores are going to be arbitrarily the worst, except for 2 of them. 1, ataxia, where you arbitrarily give them the best, and extraocular movements, where you go up and you take a hold of their eyes and you dial their head back and forth. So easy if you kind of think in that direction. Is this a good exam for coma? No. I mean, it'll be a horrible score, but it's not really distinguishing. I don't know much detail about what parts of the brainstem are working, so I'll oftentimes add in a coma patient, you know, parts of my coma exam, corneal responses and pupils and things like that to get drilled down to where in the brainstem we are. So, any questions about all that, you guys?
What about if they're intubated and on propofol or sedated or not?
Yeah. You know, very important thing, you know, I think you guys are eventually going to go to primary stroke center certification. You gotta, you know, you're going to be a great site and you know, sometime in the future. And as you get reviewed, you need to document, you know, everything that you do, like Liz was saying before, with the grind checks and the neuro checks. You got to make sure you're documenting with a certain frequency, because that's what they'll look at and check. And you know, you might have done it and gave great care, but if it's not on paper or on the electronic record, it didn't happen. So, so what we're being asked to do when we get reviewed is, if we're in a situation where we can't document, and you know, our protocol says we're supposed to, we have to say in the chart, I can't do this check because, you know, because of ICP or something, I don't know, whatever it is, we can't lift the sedation, so I can't really do a neuro check, and you just don't do it.
And then from your score, your initial score in the emergency room,
Yep.
where am I going to get that information so I can say, okay, is this a change from the emergency room to the ICU?
Yeah, depends on whether we're talking in this world or the next. So right now,
And what you scored what on?
yeah, when are you guys going to have an electronic record change?
10 years from now?
We're not now.
Yeah. Oh, okay. Yeah, so we're kind of, this is the one drawback to our work together that's going to make it a little clumsy, is that we aren't going to be diving into your electronic record using all your tools. We're going to be dictating a note that shows up. So I think, you know, once the code is done, you know, and we're in a situation where we're kind of relaxed, we're giving TPA, we're not going to go to mechanical thrombectomy, we're not racing around with, you know, our heads all exploding. We can sit down and talk through the case, and I can say, here's what I got on the NIH stroke scale, what did you get? You know, what should we put in the chart here? And just make sure. It's a good thing to do anyways. You know, I think one of the things, we don't do it as much as we used to, but we found that we had to in the beginning, is this thing where we kind of do a, you know, a post-mortem of our stroke code together right after, particularly us and nursing, because you guys, nursing, are our primary partners in the code usually. Because in a busy ER like yours, your doc is, you know, all around the place, and you guys are, you know, one-on-one with patients, so you're our big partner. And we want to make sure that partnership works well so that you can accommodate our needs to try to get to the patient so that we can get our job done in time, and we're not interfering with your job. And so at the end of the code, because we were finding the video creates sometimes enough of a barrier to understanding what's going on one side or the other, that you know, there got to be some sort of silent problems that nobody was talking about. So we went to this idea where, you know, as much as we can, you know, when you're finished with the stroke code, talk to the nurse that you were working with primarily, and sometimes the doctor too, but and say, how did things go, you know, and or if I notice something that we need to maybe improve on in the stroke code, I might bring that up, you know, after the thing is completely done, you know. So, yes, Abby?
Well, the ER nurse doing the initial NIH with her documented the NIH.
Yeah.
Can we do a sheet on paper since it's a code?
Yeah.
I mean, we create an NHS
Can we
little
get a
code
flow
sheet?
sheet of some, like a, you know, just a set of,
That's kind of.
instead of just going in the tab in the computer?
That's what-
We could have something to go by, like, makes it more streamlined and more efficient and more quick for us, and we'd feel more confident in what we're doing. If we could have something that explained each step, you know, briefly and concisely, so that we could quickly get through it, other than just the tab in the computer that we have.
The tab in the computer is laborious.
We were even thinking
It
of
is.
a flow
It's
sheet tab where we put the
Oh,
line.
that's gonna slow us down then, huh?
Well, I'm
That if we
talking
could just
about
have a
when you-
section in there that you could
Let's
just
just
pull it up
say,
fast and see the number.
if you got called for a stroke code and you ran out to the medical floor, you ran in there, your head's in a million other things that you've been doing, you're in the room, you've got a family member, it's stressful. We need something to pick up and say, okay, this is how you test for each one, very quickly so that we can eyeball it and do it.
Oh, okay, you're gonna be doing
the
the,
NIH,
Yeah.
like document
Yeah.
each
Yeah.
item on that.
Something
Just
just
make-
to guide us very quickly and remind us, this is how you test for this is what the score would be.
that'd be great.
And I wanna
And because you're gonna do that, just triaging what you're gonna do with that patient before the code even starts, so I think that's a great tool. But remember, when we're doing the exam that we're gonna count on, you and I are doing it together. And so, and I am telling you what I want you to do the whole time. So you know, when people who aren't as trained as you guys are in the NIH stroke scale, they just like, I have to do that exam, and they don't really, because I'm really doing it, I'm using their hands. And so they learn it, you know, after, 5 or 6 stroke codes, they start to get the hang of it.
Well,
There's
obviously,
stroke
I'm
codes
older
on
and
it.
I've been doing this for years, but I still think it's complicated in some
It
ways.
is,
And
yeah.
the different,
The
wording that they
interpretation is
have
particularly,
for what you should do for each step is not completely the same.
yeah, yeah. Well, and even if you get online and you certify yourself in the NIH stroke scale with those testing tapes, every examiner does it a little bit differently. Even the NIH examiners that put these tests together, they do things, they do the visual fields differently, that sort of thing.
I think if we all tested in the same way and got really good at it, that's the only way it's gonna be consistent with comparing scores.
Yeah.
And I think that tab in
Each one of them
is
is a little bit different. On our video, now they're like they're reading.
They made a book.
I think there should be just, do you want to kind of tell them, maybe connect, like maybe just go stay in the ER, connect over video, and then that way we can just.
I work in OB.
But then that way, you can connect and then that way, that's what I'm saying, will that work? Okay,
I'll just
yeah.
sit down here.
Okay.
Can I ask one more thing about your stroke code?
Okay, perfect.
Does it have to be a stroke code to consult you?
No, so we have non-urgent stroke and neurology available as well as, I'm sorry. So non-urgent is 6 hours. We don't rate on the ER.
I know, I didn't specify anyone.
If they're wanting to, for Carla, looking for a work.
She has to work here all week.
And then general body, have a discussion with the physician, and then
We're so glad you're here after hours. After hours, what the day like hand, my hand. I really don't feel like a lot of times we don't call like
actually explain our protocol. You know, like what exactly are we, and like just work through that. We're heading to video with ER for the mom.
Okay.
So we'll be.
If you have evaluations, please leave them. I think you're going to the emergency room now for the mock code. But if you want to take your stuff with you, because they're going to set up for the next one.
In other words, take your stuff, so we leave your garbage.
Yep. Please leave your evals though. Thank you.
I want to stay in here and listen to her.